Welcome to this introduction to lateral violence in nursing, as told to you by an old white dude in a Red Sox hat. Hi, my name's Gerard Susi. I'm a registered nurse certified in hospice and palliative nursing. And I'd like to talk about something that we don't talk about enough, and we don't talk about it directly and honestly. Here we go: lateral violence. The objectives for this program are simple. First, that by the end of the program, you'll be able to define lateral violence in nursing. Define it in your own words and be comfortable defining it for other people, telling other people your definition of lateral violence. You'll be able to list three specific forms of lateral violence. There are many more than three, but my hope is that there will be at least three forms that we discuss that really resonate with you for whatever reason. And then finally, my hope is that you'll be able to describe a response technique, a way to confront lateral violence called cognitive rehearsal. I also have a bonus challenge for you, and that is to identify and reflect on an instance of lateral violence where you were a witness, a victim, or perpetrator. Here are a few authors' definitions and words about lateral violence. Dr. Marshall, no, she's not a doctor, Marshall Toba-Ben, writing in Home Healthcare Management and Practice, defines lateral violence in nursing as hostile, aggressive, and harmful behavior by a nurse or by a group of nurses towards a coworker or a group of coworkers. And they do this via their attitudes, their actions, their words, and maybe even other behaviors. Herbert Dunn, writing about horizontal violence among nurses in the operating room, said, nurses will talk about each other. They'll lie, or in some way undermine each other to control, humiliate, denigrate, or injure the dignity, but also injure physically the dignity of oppressed coworkers. And we'll come back to that term: oppressed coworkers, or marginalized coworkers, or targeted coworkers. Finally, Dr. Rosemary Taylor writes that researchers suggest that lateral violence may be so ingrained in the nursing culture that individual nurses do not recognize it when they witness or experience it. We do not recognize lateral violence when we see it happen or when we are even the targets of it. That's how ingrained it is in nursing culture. So, the American Nurses Association back in 2015 came out with this new position statement on professional issues, and specifically a statement on incivility, bullying, and workplace violence. Language is important, so I would like to also return to and think about these three terms: incivility, bullying, and workplace violence. Within the position statement, I learned that the Occupational Safety and Health Administration, OSHA, has categorized different types of lateral violence, different types of workplace violence. And the kind of violence we're talking about here with lateral violence in nursing is type 3, where employees threaten or attack other employees. It's not employee on patient and family on employee, but rather type 3, employees who attack or threaten another employee. The statement also includes this: that those who witness workplace violence and do not acknowledge it, okay, now remember the earlier statement, people don't even recognize it when they see it. But when you witness it, acknowledge it. If you don't acknowledge it, if you choose to ignore it, if you fail to report it, you are in fact perpetuating it. You're keeping it going. You're participating in it in a very real way. Now, in that statement, when they talk about witnessing workplace violence, they identify two things that we should do, right? Acknowledge that this is what we're seeing, this is what's happening in front of us, and then reporting it. Those are two actions, but we really need to consider then what and what else. I'm going to leave those questions hanging for a moment. All right, so here's my Red Sox. Here's what my Red Sox hat looks like now, and we're going to use it as a time machine. We're going to hop through the hat back to the year 2004. That's an important year because that's when the Red Sox won the World Series for the first time since 1918. It was also the first year that I made the majors myself and got a job as a nurse at Big Wicked Hospital. During my orientation, I met Dr. Martha Griffin, who taught a class based on this research that she conducted, teaching cognitive rehearsal as a shield for lateral violence, an intervention for newly licensed nurses. So we'll just take a look at the abstract. First off, Dr. Griffin identified newly licensed nurses as a vulnerable group, a group vulnerable to lateral violence. We talked about marginalized, targeted, uh, differences, reasons that people can be targeted for lateral violence. And being new on the job and new in the facility, in the place, is a risk factor for being targeted. Newly licensed nurses, in particular, because they're young, they're just out of school, um, and they stand out. And they have needs. They have needs for learning and for being supported. So, in this study and in her approach, Dr. Griffin teaches nurses about lateral violence, what it is, what it looks like, and also the use of a cognitive rehearsal technique that is a way to confront and address and resolve lateral violence. Okay, cognitive rehearsal. And cognitive rehearsal includes this tool, a small laminated cue card with written visual cues for the appropriate responses to the most common forms of lateral violence. Cheat sheets that you could put on your lanyard or on your badge reel. And this is what they looked like. Here's one side of that little, small ID card cheat sheet, and it identifies 10 forms of lateral violence, the most frequently encountered forms. We're going to talk about these individually. It's difficult to see them all in small print, and they're important. So, she taught these nurses about lateral violence. She taught these nurses how to respond. She provided these nurses with tools to respond. And in follow up a year later, conducted some focus groups and had some questions to elicit responses and discussion about their experience. And what they learned was that the responses, the cue cards, really helped them confront the lateral violence offender and confront them in the moment. You're with a colleague, something happens, it feels like lateral violence, it smells like lateral violence, it looks like lateral violence. You review your cue card and you've got a response. It's difficult. It really is difficult. We can't deny that. But this kind of intervention, direct, clear, and in the moment, can result in resolution of the behavior. All right. So let's break this down individually. This is the bulk of our discussion today. So the first on the list is nonverbal innuendo. Um, what does innuendo even mean? Well, it's an oblique allusion. It's a hint. It's an assiduation. It's saying something that's kind of like, what did they just say? But what they're saying is a reflection on character or reputation, and it's veiled. It's kind of hidden. So nonverbal innuendo as a form of lateral violence can take the form of facial expressions in response to something that a person may say. You know, I ask a question, somebody rolls their eyes. I've asked a stupid question. Is my question not appropriate? What's being communicated here? Um, Making fun of someone. It can also be indicated by posture. You know, I'm looking for help, and someone is just standing there like a stone, or they just can't believe I'm so dumb as to need help for this thing. But they haven't said it, and it's even deniable. That's important. Deniability. All right, so nonverbal innuendo is the first form. The second is a verbal affront. Now, I also had to look up affront. So we're talking now, or we've got words and sounds, but what is an affront? An affront is it's an insult. It's an insult to your face, um, and it may be something that is said, or going back to the nonverbal behavior there. So it's deliberate. It's an insult. So the second most commonly encountered forms of lateral violence are insults to your face, right? They may be covert. It may be kind of muttered under somebody's breath. It could be someone swearing at you, being sarcastic, or again, deniability, the idea of, well, I said that, but I was just joking. Can't you take a joke? Um, and another form could be, the kind of abrupt response. You approach someone respectfully asking for help, and they turn around and say, "What? What do you want?" Yikes. Okay. Third form, undermining. That's turning away or becoming unavailable when someone needs help. I need help. I turn around. There's nobody there. I'm on my own. They went away. Similarly, withholding information, not telling somebody something that they need for a practice. I didn't tell you everything you need to set up the room, or to set up a tray for a procedure, or I deliberately didn't tell you something about a patient or family member, just to kind of, you walk into it, you deal with it yourself. Now you can see how we're also, things seem to be getting a little more violent. Sabotage is deliberately setting up a negative situation, doing something so that someone will fail. And, you know, I didn't do that. Who, me? Someone who is going to act in this way toward a colleague may be just as skilled at avoiding accountability and hiding their behavior. Infighting is really bickering within a group. It's where you take up sides, where you gang up on someone. Um, and it's petty. It's not like there's a serious issue in the unit around practice and people have different thoughts about it and it's an intense conversation, but it's about something important. Now, bickering is petty arguing amongst peers. And the thing is, it escalates. Small things become very big. Scapegoating is pointing to someone or some group and saying they're the problem. They're the reason things are difficult here. Backstabbing is doing or saying something about someone behind their back. They're not there to address it, to defend themselves, to set the record straight. Failing to respect privacy. It could be barging in on places or conversations that are taking place, or it could be more sneaky and listening in, but not stepping back and respecting that something private may be going on. And then finally, breaking confidences. Something is shared with us, and we say, "Oh yes, I won't tell anybody." And the first thing we do is tell somebody, tell everybody. So that's the list of 10. What I'd like to do is go in more depth into two particular forms in particular. And this is another part of the tool for Dr. Griffin's intervention. And these are the cue cards for the cognitive rehearsal, for the things that we do. Um, we'll take a look at cognitive rehearsal as it applies to sabotage, how to respond to a system, how to respond when we think something, how to respond when we think we've been sabotaged. And the other is a response for to someone who is backstabbing. All right, so sabotage is deliberately setting up a negative situation, and Dr. Griffin's suggested cognitive rehearsal is to confront the person in as neutral a way possible and say, I think there's more to this situation than meets the eye. Could you and I and the nurse manager meet in private and explore what happened? Now, again, see here, we've got someone who caused violence, and in the face of that, it's important for us to maintain some level of composure to confront it. You could see why they said the students in the study said it was difficult. All right, backstabbing is complaining about someone who's not present. And the suggested response is, I don't feel right talking about them. I wasn't there. I don't know what happened. I don't know the facts. And if a person is complaining about someone, an appropriate response for us would be, well, have you spoken to them? Have you taken it up with them? All right, time travel from 2004 when I learned this stuff to 2007. And 2007 in Red Sox years was Clay Buchholz's no hitter against the Baltimore Orioles. And I went to that game. I saw that game. It was amazing. And I was there with a friend from work because I worked in a 20-bed specialty intensive care unit that had many men on staff amongst the 100 plus nurses. And there were a lot of Red Sox season ticket holders amongst those guys. So there was always a seat available unless they're paying the Red Sox. So it's night shift, and a colleague, we'll call her Leslie, is trashing another colleague, Amy, who isn't there. This is what Griffin calls backstabbing. And so the cognitive rehearsal is, I'm uncomfortable. I don't feel right. And Tony and I were there. Tony and I were amongst the nurses that were kind of standing around while when Leslie went into trashing Amy. And it was really quite, it was violent. So it would have been appropriate for Tony and I, really everybody there, to respond to Leslie, to kind of shut it down. And, I'm uncomfortable. I don't know the facts. You're talking about Amy. Have you talked to her? Uh, but no, Tony and I, like, looked at each other, were horrified at what was happening, and we just kind of backed away slowly. And it was shameful. We were horrified by what we were hearing, and also that we were just too chicken to do anything about it. In baseball terms, we struck out and looked really stupid doing it. And somebody got hurt. See, that's the other thing. We're not just bullies depend on this, though. They depend on this response. They depend on shock and intimidation and silence, so that people don't confront. It's difficult enough. The other thing about bullies and bullying and this kind of backstabbing and people listening in is they also get support. They get overt support, people agreeing. They get covert support, which essentially is what Tony and I did. We didn't, you know, we perpetuated it. And bullies also get agreement that, yeah, you know, that person is no good or whatever. So it's a mess. Um, but because it's such a mess, you can see how important it is to clean it up. I mean, this is what happened. All right, let's travel now back in time to 2006, which is a year that the Red Sox didn't win the World Series. They finished in the middle of the division. And I got I came into work. I was on a different unit, and I came into work late in the week on a Thursday, and hadn't yet gotten my schedule for the next time period, which began on Sunday. So I came in and I saw it, and this is what I was going to be working the following week. Um, Monday night, off Tuesday night, on Wednesday night, off Thursday night, on Friday night. So on, off, on, off, on. And I'm not a young guy, and my response to the nurse manager was like, I can't work this. I mean, I literally physically can't work this. I'm feeling sick just looking about it. This is going to mess me up for the entire week. And she said, yeah, I don't care, whatever, do switch. But it was very dismissive. She caused the problem, but wasn't going to help be part of the solution. So I just kind of put out a desperate call, and thankfully someone said, sure, you know, um, take my Tuesday, I'll take your Friday. So I thanked them, and she pointed out, she said, yeah, this nurse manager does the schedule at the last minute, and she does it in front of the TV. She brags about it. She lets everybody know that, she doesn't care about our schedules. And, I was fairly new on the unit, and that hadn't really sunk in. It was pretty shocking. Later on that shift, the same nurse and I were having a conversation, and it was a conversation based on the theory of, all right, you've got a 100 ml bag uh, to run in of an IV med to run in over an hour. What rate do you set? And I said, well, you've got fluid in the tubing in front that you need to clear before the med hits the person, and then you've got all the med in the tubing to clear, so that they get all of the med. So a rate of 125 an hour would include the volume before and after the bag. And she said, nope, nope, nope. She was pretty insistent. It's 100 an hour. And, again, it was a conversation. It wasn't a problem solving session. So shift ended. I went home, come back the next week to kind of work my first of three. Hello, everybody. And bang, the hammer came down. The nurse manager was there, and she said, we've got a problem here, serious IV bed errors. And where did this come from? What are we talking about? And the other part of it is that people were kind of waiting for me to arrive. They were kind of waiting to see the show. Um, Ended up having to have a meeting, and since we have collective bargaining, I had a union rep colleague with me for the meeting, and she basically said, "Listen, why don't you just get the heck out of this unit, and let's find another place for you." So that's what we did. All right, so I don't know, was that sabotage? Um, the whole thing left me feeling very uneasy. There's more to the situation than meets the eye, but where and how do I even begin to take it apart? you know this stuck in my mind for a while, and it was only in the last few years that I got onto a concept that kind of helped explain some of my unease. But the idea of gaslighting, where you're presented with the kind of manipulation from an abuser that results in self-doubt and confusion in your own mind. Like, my confusion and self-doubt was like, wow, am I really a dangerous practitioner? Did I imagine what happened? Um, and that's an important point, because people who gaslight others, they're trying to maintain power and control, and they're trying to get them in their own minds, the victim, to question their own judgment and question that, did I see what I saw? That's pretty heavy to think about. Here's something else heavy to think about. And this is my late wife, Jean, who was a nurse and a clinical nurse specialist in adult psychiatric and mental health. And one of the things that she talked about was that, the workplace is often where we recapitulate unresolved issues from our family of origin. The workplace is a place where people's stuff from earlier in their lives can come out. Um, One illustration of that is a colleague looking at me in exasperation and saying, You remind me of my ex-husband. I'm not her ex-husband. And, kind of bringing him into this seems kind of weird. Um, if there was something that we needed to discuss, let's do it directly. But the workplace is where we can recapitulate unresolved issues from our families of origin. We bring our stuff with us, and people will dump their stuff on other people. All right, let's go to 2020, which was, yeah, not a good year for the Red Sox. It was also a shortened year because of first year of the COVID pandemic. And that's the year that a national nursing workforce survey was published. It's actually published every 2 years, but I drew on that issue um, to talk about who are nurses. What does the nursing profession look like demographically? 90%, over 90% of nurses are women, and over 81% of nurses are white. Just over 7% are Asian or Asian ancestry. 6.7% are black, and that's half the rate of the black population in the general American population. And 5% are Hispanic Latine. So it's an overwhelmingly white female profession. If nursing was a college or university, one of the top 100 universities in the country, um, we'll take a look at how diverse it is or isn't. So the top 16 universities here, you can see the different demographic groups portrayed by color lines. So blue is the population of percentage of white undergraduates. Green is black undergraduates. Um, Yellow is Hispanic undergraduates, and red is Asian undergraduates, and purple is other. And you can see at the top, Stanford University is the most diverse school because it's got a very broad mix of people. Um, here, here's the 50% line. So all of these top 16 are less than 50% white. Here's the bottom 16, the numbers 84 to 100 of the least diverse colleges and university amongst the 10 of the 100 top colleges and universities. And if nursing was a college or university, it would rank with the University of Vermont and Brigham Young University and Clemson as overwhelmingly white, with a small percentage of black and other ethnic minorities. That's nursing, the bottom of the list for diversity. Okay. Lateral violence, bullying, I mentioned language earlier. I think incivility is a pretty weak word, and civility is a pretty vague word. Um, Lateral violence is a stronger word, and it makes you think, and certainly the word violence stands out. So here's from a New Yorker issue last year. Cartoonist Liana Fink identified several forms of types of veiled criticism. Lateral violence, veiled criticism. It's more polite. Backhanded compliment could be another kind of wordplay on it. But this is how she depicts withholding, right? Um, in this depiction, it's just being unavailable, it's ignoring, it's not giving somebody something that they need. Um, and she's just a nice lady. So that's how it can look. All right, so back to the ANA's position statement from 2015 about incivility, bullying, and workplace violence. We've discussed a few forms. If withholding, if you wanted to look at it as a relatively mild form of violence, I don't necessarily agree, but let's kind of put it in that context. Then backstabbing is more intense, more violent. Sabotage is even worse. Um, how bad can it get? Well, I think all of them are eclipsed and encompassed by looking at racism in nursing. And Even the American Nurses Association has come to recognize that there's a lot of racism going on and something's got to be done about it. That will be the topic of the next in this series of videos. Thanks for watching. I hope we meet our objectives.